is Dr. Lyle Jones, Editor-in-Chief of Continuum, the premier topic-based neurology clinical review and CME journal from the American Academy of Neurology. Thank you for joining us on Continuum Audio, a companion podcast to the journal. Continuum Audio features conversations with the guest editors and authors of Continuum, who are the leading experts in their fields. Subscribers to the Continuum Journal can read the full article or listen to verbatim recordings of the article by visiting the link in the show notes. Subscribers also have access to exclusive audio content not featured on the podcast. As an ad-free journal entirely supported by subscriptions, if you're not already a subscriber, we encourage you to become one. For more information on subscribing, please visit the link in the show notes. AAN members, stay tuned after the episode to hear how you can get CME for listening.
This is Dr. Allison Weathers. Today I'm interviewing Dr. Ricardo McFaline-Figueroa on Spinal Cord Neoplasms, which is part of the February 2024 Continuum issue on Spinal Cord Disorders. Dr. McFaline-Figueroa is a physician at Dana-Farber Cancer Institute in Boston, Massachusetts, and an instructor in neurology at Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to the podcast. You do a really fantastic job in the article providing a comprehensive overview. But if you had to come up with the most important clinical takeaway from the article that you want our listeners to walk away with, what would that be?
I think the most important thing to remember about tumors of the spinal cord is, one, that there is no specific diagnostic feature on imaging that can be used to determine what a neoplasm of the spinal cord is, or even if it is a neoplasm. So I think, going in broadly when you're looking at a mass lesion of the spinal cord is very important. And then the second is just to know that there's just such a wide range of cancer possibilities that can do this, that getting an appropriate diagnosis becomes very important.
I think two really salient points right there. And I want to kind of explore something that you said a little bit more. So you talk about the concept that there's no one kind of diagnostic feature of the MRI. And actually, I was thinking about this as I was reading your article. What struck me too is that holds true actually for the patients presenting signs and symptoms, right? So as a neurohospitalist, I'm constantly struggling with always how to balance not missing a diagnosis such as this, a diagnosis of spinal cord tumor, versus putting a patient through what can be an often unnecessary and very costly workup, right? So this is such a rare diagnosis, but the presenting symptoms and signs, such as back radicular pain and weakness, are shared by so many common conditions. What's your approach to distinguishing between them? And what are some of the red flags you look for to know when further workup really is indicated?
Certainly. I think, there's not one way to decide whether you need to go down the route of exploring a neoplasm of the spinal cord, but there's certainly things that would clue someone into this needing to be the case. I think one is, as opposed to a lot of the monophasic illnesses that we see in neurology, certainly it's something that is progressive. Is certainly something that increases the certainty, and it's different from, ischemia of the spinal cord or an acute demyelinating event. I think another important feature is also just the context. I think, even though these are rare, when you're dealing with a patient with a known history of cancer, that's when the rare becomes common, and that's when you have to really start thinking about it being a neoplasm of the spinal cord. It's still not perfect. I mean, it covers some of the side effects of treatment that can look a little bit like a spinal cord neoplasm, but certainly that should increase the level of suspicion for something going on in that compartment that's neoplastic.
I think that's such a great take-home quote for our listeners to think about when the rare becomes common. And you actually hit on the point that I wanted to ask you about next. So in neurology, we always talk about how important the history and the exam are. It's kind of our core of what we do. But it feels especially true when talking about neoplasms of the spinal cord. And you mentioned, obviously, the big one is that if they have a history of cancer, especially an active history, that's a pretty big clue that something more serious could be going on. But what else is key in the history? Why are the history and exam so especially important when you're concerned about or dealing with neoplasms of the spinal cord?
When we're dealing with the spinal cord, we're dealing with a lot of different compartments. And I think to your question, The one where thinking about history and physical becomes the most important is when you're thinking about the possibility of leptomeningeal involvement, right? So the leptomeningeal space is not easily imaged, right? We can't really see much what's going on in the CSF. And so we rely on imaging-wise and there being deposition of cancer cells along the dura or along the direct surface of the cord. But oftentimes that's not the case. And that's when, knowing exactly what someone's cancer history is, what their stage in the natural history is, whether they're progressing or not progressing, have some knowledge of what the oncologic medications that they're on are, because brain penetration is different for several of them. And then really hearing for those signs and symptoms that are connected to that compartment, signs of increased intracranial pressure, signs of cranial neuropathy that may or may not be evident on imaging, radiculopathies. So those are the things that are very important in all investigations of spinal cord tumors, but certainly for leptomeninges. It's often the case that really history and physical are all you have to try to get the diagnosis right.
You make actually a really great point in the article that I think it bears kind of mentioning here, because I was embarrassed when I read it, because I said, I have been guilty of that the history of kind of these very generic histories of cancer, they had lung cancer, is probably not sufficient, right? That there's value in getting really specific. Why is that?
That's certainly why we all specialize in different things, right? For a neuro-oncology standpoint, it sounds very different to me to hear the same history in a patient with melanoma versus the patient with bladder cancer. You think of melanoma from a neuro-oncologic standpoint, you're thinking of a cancer that is incredibly trophic for the brain and spinal cord, probably because it's derived also from ectoderm, so it's kind of the same origin of the cells. And it just makes your level of suspicion go so much higher when you are in that mind space of thinking of a melanoma patient versus someone with a tumor that very rarely, if at all, goes to the central nervous system. So I think that's something that's really important. And those are two big extremes, but even, like I mentioned, even in lung cancer, certainly small cell versus non-small cell are very different in terms of when and how they can affect the spinal cord or any part of the central nervous system. So that one's a little bit more nuanced in being a neuro-oncologist, but still as specific as you can be when you're discussing with your neuro-oncology colleagues or medical oncology colleagues, then the better for trying to figure these things out.
An excellent pro tip right there. And you were very gracious about that. We all have different specialties. And I was reflecting on that too. This is such an important, yet definitely pretty specialized topic. How did you become interested and develop your expertise in it?
My clinical work is on all sorts of tumors of the central nervous system. Actually, in neuro-oncology, we also do a little bit of peripheral nervous system tumors, depending on how they present. And, it's all a continuum, not to use that. Well, we just happen to be a continuum. But, it's all a continuum, brain, spinal cord, it's all one big compartment. And so it forces you to be really familiar with all of those. And I think it's an interesting topic. We don't talk about it as much as we do for some of the other, cancers of the brain, for example. And in terms of becoming an expert, for me, a lot of it is, just at this point, experience. And then I will say a lot of reading, because you don't see all of these. I cover some topics like primary glioneuronal tumors of the leptomeninges, which are incredibly rare. I have never seen a patient with one. But it's one of those things where you should know the basics of these, at least for my field, and certainly beyond.
What about neuro-oncology in general? How did you decide that you wanted to specialize in that?
Well, actually, me personally, I spent a lot of my residency trying to decide between being a neurointensivist and being a neuro-oncologist. I think for me is that I like taking care of patients who are, potentially very sick. I think I just enjoyed the process of the more longitudinal relationship that you have as a neuro-oncologist, seeing people in clinic, walking them through all these treatments and, difficult disease courses. And that to me, I just found really fulfilling, while still having, lots of internal medicine to think about, lots of interesting neurology, just in a different context.
It's such an interesting field. And I was also really thinking about this, that while neurology overall has had so many incredible advancements in terms of diagnostic and therapeutic capabilities in the last several years, neuro-oncology in some ways is almost like an entirely different field since I was in residency training, which wasn't all that long ago. How have these changes impacted how you diagnose and manage spinal cord tumors?
Certainly, there's been a lot of changes in technology that I think have been helpful. And then certainly, slowly but surely, we are coming up with better treatments for patients. So when I speak of technologies, the one thing that, for example, comes to mind is, historically, it's just so difficult to diagnose. I keep coming to the same anatomic compartment, but it's so difficult to diagnose leptomeningeal carcinomatosis or leptomeningeal involvement by a tumor. Even more so, I think, in the spinal cord, because it's just difficult to catch on imaging. But over the last few years, so many advances in like molecular testing of cerebrospinal fluid to be able to look for cell-free DNA, to be able to enrich for rare cell populations and then identify them, which really kind of has changed that we need to do 3LPs mentality. We have things that are sensitive enough that are rolling out. And in terms of treatment, certainly the field is changing. There's so many now targeted therapies emerging for tumors as we understand the biology, which is probably the biggest roadblock to better care for the primary spinal cord tumors. It's also a very exciting time to be in neuro-oncology because of that.
And perhaps a less positive note, the field's changed so quickly. Has this led to any controversies in the field?
I think the biggest controversies are less so controversies in the traditional sense, and that I don't think anyone's fighting with each other, but it's become really difficult to know, particularly as those therapies that I mentioned come out, what is the right first step? Is the right first step for somebody to have, for example, well, actually, this is less controversial now, but for example, someone with von Hippel-Lindau who might have multiple hemangioblastomas. We're reaching a point that with approvals of targeted therapies for that disease, you might not necessarily go for surgery, which could be quite morbid in some instances, or radiation for progressive disease. And so I think one of the issues there is that we're not necessarily at the point where we are sure that, definitely the intervention with the longest survival is targeted therapy first, and then maybe surgery, and then maybe radiation versus the other. So I think the order at which we treat these tumors is just a little bit in flux.
And hopefully with time and more evidence that will become more definitive and clear. And you just mentioned, just in that answer alone, surgery and radiation. And the other really fascinating thing about this topic, about neoplastic spinal cord, is how truly a multidisciplinary effort the management of patients with spinal cord tumors is. What other specialists do you work with to diagnose and manage this patient population, and what's everyone's role in these cases?
So certainly, neurosurgery still plays a huge role, particularly because even when you are relatively sure that it's a tumor of the spine, particularly if you think it's a primary tumor of the spine, there's really no diagnostic test that's just imaging. Like the only way that we have to establish the diagnosis is through tissue examination. In neurosurgery, in a lot of diseases, still plays a huge role. For example, ependymoma is one where really gross total resection is one of the biggest, if not the biggest, prognostic factor in treatment. Radiation oncology, there are still histologies that we have no good systemic therapies for. So, for example, for diffuse midline gliomas, most of them are not very sensitive to the therapies that we have that are systemic. And so for these tumors, it becomes important to do radiation as the most significant step in management that we have. We just don't have anything efficacious for those tumors at the moment, although we're learning a lot about the biology. A lot of these have histone mutations that people are trying to target for more effective treatments. So radiation oncology, again, still plays a huge role in the treatment of our patients. And certainly when you're dealing with patients with metastatic cancer to the spine, medical oncology is huge. And that's where me as a neuro-oncologist, I'm less of an oncologist and more as a person who the medical oncology can bounce ideas from. We sit down and talk about their expertise and how to treat these tumor types, and then me bringing in, what might be brain penetrant, what things may or may not be toxic to the nervous system, stuff like that. So it's really a group effort, and that's not even mentioning nurses, nurse practitioners, amazing people who coordinate care and stuff like that. And, like I mentioned early on, one of the most important things is to know exactly what type of tumor or cancer these are before proceeding with any conversation about treatment. And that's where, our neuropathologists really drive the direction of what we're doing.
Even as I was thinking about this question and in my mind, what I thought your response might be, that was even more of a complex team than I think I had envisioned. And it really speaks to, again, the true multidisciplinary effort, the team of teams that's needed to provide care for these patients. And I think I heard you say this in that wonderful answer, but that as things are evolving and as we are better understanding the biology, that we're getting better with our targeted treatments, but that could possibly include at some point even targeted therapies for midline gliomas, which would be incredible. I know that's always been one with not only an especially poor prognosis, but given the population it tends to affect of younger patients, it can be quite devastating. So that definitely struck me as I heard you say it. So I think this is a field where, we're going to continue to see so many breakthroughs. And that leads me actually into my last question. I always like ending these on a hopeful note, and I think that certainly does it. But we've talked about so many changes already, and again, I know even more to come. What do you think the next big breakthrough will be? Did we cover it already? Is there anything else that you're excited about that's coming down the pike?
I think we covered some of it, which is really being able to bring more systemic therapies, more, oral therapies or intravenous therapies that treat these tumors, as opposed to things like aggressive surgery or radiation, which are effective, but the hope here is that we can delay those so that we can have people living longer with these cancers or cured of these cancers, and trying to spare them as many side effects of treatment as we can, which historically in the spinal cord is quite significant because it's a difficult space to do surgery on, and it tolerates only a certain amount of radiation before coming into toxicity. So I think it's a really exciting time to be on the medical side of things as a neuro-oncologist and see all these treatments coming in that really improve people's quality of life.
Definitely an exciting time to do what you do. Well, again, thank you for the incredible article, for taking the time to speak with me today. Any last thoughts for our listeners?
Just, be mindful when working up those spinal cord tumors. There's a lot to think about, but there's also a lot of good can be done by doing good diagnostic workup.
Thank you, Dr. McFaline-Figueroa, for joining me on Continuum Audio. Again, today we've been interviewing Dr. Ricardo McFaline-Figueroa, whose article on Spinal Cord Neoplasms appears in the most recent issue of Continuum on Spinal Cord Disorders. Be sure to check out Continuum Audio podcasts from this and other issues. And thank you to our listeners for joining today.
This is Dr. Tishme Monteith, Associate Editor of Continuum Audio. If you've enjoyed this episode, please consider subscribing to the journal. There's a link in the episode notes. We'd also appreciate you following the podcast and rating or reviewing it. AAN members, go to the link in the episode notes and complete the evaluation to get CME for this episode. Thank you for listening to Continuum Audio.